हाँ ठीक है ना, ये तो ठीक ही है ना।
All right. Thank you so much, team. Very good evening, everyone. I'm Dr. Rajeshri Dhar from the medical team. I'm honored to welcome you all to this live workshop on where we will be delving deeply with difficult to treat interesting cases on thrombosis and explore how real world clinical insights from you can actually transform the treatment of stroke and also help with better outcomes. To start the program, let me kindly introduce our course director, Dr. Subhash Kaur sir. He is one of the India's most distinguished neurologists, and to welcome him, we are grateful.
Slide has
Dr.
not moved, ma'am. Sorry to interrupt. Yes, yes. Now it is fine. Thank you.
So Dr. Kaur brings over 40 years of clinical experience to this field and also currently serves as a senior consultant at Department of Neurology at KIMS Hospital, Hyderabad. He has authored multiple scientific publications, over 105, and many book chapters, over 20, and delivered over 300 lectures, including several prestigious orations as well. Doctor has served as a principal investigator for multiple national and international clinical trials, including ICMR funded work, and has been committed academic mentor training over more than 50 DM neurology students during his 30 years of teaching experience as well. He has exceptional range of achievements. I won't read them out. A warm welcome to you, sir, on behalf of Gennova family.
Thank you.
Let me now welcome our moderator, Dr. Praveen sir. He'll be joining in some time. So he's a consultant neurologist. Uh, he's a consultant neurologist at KIMS Hospital, Hyderabad as well. He has presented several prestigious neurology meetings, including AP NSA, Econ, API, and many more, and also in World Congress in Controversies in Neurology. And he is
Sorry, ma'am. Slide is not. Sorry. Yeah, now it's fine.
So he's been a part of World Congress controversy in neurology, and he's contributed a lot of academic literatures as well in neurology. Doctor has been an active member in Indian Academy of Neurology and in Indian Stroke Association. We are very pleased to have him with us here today to guide us and lead the scientific program ahead today. So moving ahead, let me kindly welcome our speakers, our distinguished speakers, Dr. Shashank Jaiswal, our first speaker. Dr. Jaiswal actively practices clinical neurology with a very strong focus on acute stroke care and interventional neurology. He is currently an interventional neurologist at Care Hospital, Banjara Hills. He has presented impactful researches, including in platform presentation as well at AAN 2023 and also a JME study. He also has ongoing stroke research currently under review. We are very much delighted to have you here, sir, and your case that you'll be sharing with us. A warm welcome to you, sir, on behalf of Gennova family. Lastly, let me kindly introduce you to our second speaker, Dr. Shivram Rao sir. He's a consultant neurophysician at Yashoda Hospital, Secunderabad. He brings over 9 years of rich experience specialized in stroke, neuroimmunology, and critical care. He has presented a lot of his work and also delivered in national and international forums, neurology conferences as well. So a warm welcome to you, sir, on behalf of Gennova family. With this, I would be handing over the session to our course director, sir. Over to you, sir.
Thank you very much. I think it's uh, as always, these are very innovative sessions in which we discuss about the experience of our neurologists, generally young neurologists, and we learn from them, because you can't learn complete medicine or complete neurology through textbooks, because textbooks only tell you what is the average of all the patients. Textbooks tell you the standard thing. But when the patients come, they come in different hues and colors and permutations and combinations, and it becomes very difficult sometimes to take a decision. And we actually learn from each other, as Miller Fisher has said, neurologists learn neurology stroke by stroke. And that's what has been going on for the last few years. We have learned stroke by stroke. So today, it's my pleasure to welcome my young friends, Dr. Shashank and Dr. Shivaram. We are going to share their experience and learn from them. Over to you, Dr. Shashank.
Thank you, sir. Good evening. Initially, I was planning to present two short cases, sir. If time permitting, I'll try to do the second one. This
Okay.
first case, I call it the bridge less traveled. Now, this is a Mr. NP. He was a 54-year-old male with vascular risk factors of diabetes for the past 2 years. He was hypertensive, long-standing hypertension, no history of CAD, so he was antiplatelet naive, and pre-morbid MRS was 0. This patient presented to us, this was during my fellowship last year. He presented to us at a 2-hour window with symptoms of a large left MCA territory stroke. On presentation, he was drowsy, had mild respiratory distress. BP was 170/90. He was globally aphasic. He had right human facial paresis and right hemiplegia with a power of 0. And IHS was amounting to 24. And he had gaze preference towards the left, and MRS was 5. So this patient, we had an MRI-based center. So we subject this patient to an MRI brain stroke protocol, where we could see that there was an infarct in the left lentiform nucleus with possible small extension into the limb of internal capsule, and there was some extension of the corona radiata. Issue with this patient was there were also established flare changes that were seen on flare, and GRE did not show any blooming. So at the get-go, we knew that there was diffusion and NIHS mismatch, where the patient had cortical signs, had NIHS 24 with large symptoms of large vessel occlusion, but the diffusion only showed infarct in the subcortical area and the lentiform nucleus with the cortex preserved. Now, this kind of scenario, we would possibly initially would think that patient had a long-standing ICAD in the ICA that was deceased, and that has now presented with a chronic total occlusion, where they usually present with a subcortical infarct, and the cortex is well preserved with collaterals from the ACA or the PCA leptomeningeal collaterals. But this patient had definitely some collateral failure since he had global aphasia and cortical signs and features of LVO. The GRE showed a possible thrombus in the left proximal M1, and MRA TOF was suggestive of occlusion of beyond the ICA from the Peters segment onwards. Now, this was possibly a pseudo occlusion because on MRA TOF, we could see that the filling was, albeit slow, we could see filling up till the supraclinoid segment, and beyond the proximal M1, filling was not noted. And there was no filling noted in the higher cortical branches, possibly again due to collateral failure and slow flow in the collaterals. So to summarize, we had a 54-year-old male, diabetic hypertensive with an anterior circulation LVO, a left M1 proximal occlusion, and aspects NIHS mismatch, and established subcortical flare changes with probable collateral failure. He possibly had a high clot burden as evidenced by the GRE, and which might not be amenable to IVT. But also we had concern that it might be an ICAD with collateral failure, which might not be amenable for mechanical thrombectomy. So the question now here, it was very simple. If it was a CT brain that was done for this patient, there would possibly be just a hypodensity that was noted in the lentiform nucleus. This patient would receive altiplase based on, since he was meeting the eligibility criteria, or a tenecteplase, and he would then go on for mechanical thrombectomy, irrespective of how he would fare in the future. With might not have developed hemorrhagic transformation. But since this question is begged to be answered because now this patient had undergone an MRI and then had flare changes which are established in the subcortical area. And then there was also diffusion aspects mismatch. So now would this patient fare better with a direct mechanical thrombectomy or versus bridging thrombectomy? Was at that moment a question arose at that time. So I would, I wish I had a poll here, I could ask everyone what they would do, but I just went back through the review of literature, and a few ideas here that I'll share, where I thought of while reviewing for this presentation. So the present standard of care, the zeitgeist favors bridging. There is no doubt about that. Why? Because all the first of all the direct head-to-head comparison trials between direct MT and the bridging therapy showed that there was no superiority with the direct MT compared to bridging therapy in terms of disability at 90 days and hemorrhagic transformation. But also interesting to notice that it was non-inferior. Secondly, intravenous alteplase before EVT. Why is it hypothesized to be beneficial? Is that that increases the incidence of early reperfusion. But we know that infrequently it does not recanalize large vessel occlusions, especially patients with large burden. And then after the MT, they are at a high risk for hemorrhagic transfusion and a large subcortical bleed. Secondly, that's why the bridging therapy is favored is because they say that it can lyse the distal emboli after thrombectomy. But this can be managed with intraarterial alteplase if the need arises on table at a lesser and a more concentrated dose. Other trials that were ongoing and a few that have been just completed in the past few years were Mr. Clean, no IV, Swift Direct, and another Egyptian study called with this NCT 031. They were majority were CT and CT perfusion based, and they did not really differentiate between the type of stroke. Now the question of flare. Now, why did this patient develop flare hyperintensity in the subcortical area while the cortex was still not preserved? First thing, possibly in our patient because he had very high sugars when he came. He had a sugar of around 320. That is associated with early flare changes. But we need to understand that flare is just a temporal marker. It gives a clue that 4.5 to 6 hours might have elapsed in this patient or might not have elapsed in this patient. It is a wake up stroke trials. Patients who were planned for mechanical thrombectomy were excluded from the study. 1/4 of strokes can develop changes as early as 3 hours of flare changes. Flare changes are also, and it has been established again and again as with these few trials that I have shown here, that flare changes are associated with worse outcomes and symptomatic ICH following IVT. So moving forward with this patient, we chose to go ahead with a direct mechanical thrombectomy. It was the door to puncture we were at. Now this is not a disclaimer here that this is not the standard of care that we would advise otherwise, but we were able to achieve quick door to puncture times, and our center is a thrombectomy capable center. So we were able to achieve good door to puncture time of around 1 hour. So at 3 hours I'm sorry, there's a door to puncture time was 1 hour here. He was wheeled to the cath lab for mechanical thrombectomy. So on DSA, I could see that this is the right side, and the left side, you could immediately see there's a right proximal M1 occlusion with the absent of the blush that is noticed with the lenticulostriate arteries. Possibly there was some compensation via the recurrent artery of Hubner from the ACA, but it was not sufficient. I am sorry I could not show the videos, but there was leptomeningeal collateral flow. Let me just get my laser pointer here. There's leptomeningeal collateral flow via the ACA that was compensating the left MCA territory. That's why possibly the diffusion changes had not come in yet, but definitely they were undergoing failure as this patient was clearly showing signs of very high NIHSS. And also this another thing I want to add is that this abrupt cutoff was suggestive of more of a cardioembolic thrombus rather than an ICAD. So then that also explains why possibly the collaterals were failing. So patient underwent mechanical thrombectomy. Here we went with this. We were able to achieve. This is the check shoots. We could see that after the first aspiration, we were able to aspirate the clot, and there was good perfusion following the aspiration with the TK3 recanalization. And this was the clot. You could see there's a very large clot burden, which possibly would not have responded to IVT. This is the before and after images. And this is the CT brain at 24 hours, which is showing some edema. There was some hemorrhagic transformation. But again, you can see there was little bit of harm, which is like hyperintense acute reperfusion marker, which is suggestive of cortical hyperintensities, which is possibly because of cortical diextravasation. But the cortex was spared, was not infarcted. The surrounding area was hypodense because of the edema, and there was a mild hemorrhagic PH2 possibly. No, sorry, HI2 hemorrhagic transformation. NIHS at 72 hours was already improving. It had come up to 10. This is 3 days after the procedure. His comprehension has improved. He's following commands. Power has already gone above 3/5 in the right upper and lower limb, and he's showing his tongue and following commands. And finally, at discharge, his NIHS was 4. So, but this is again a disclaimer. This is not the standard of care, but this raised a few questions that I thought would require some investigation into it. Like first, basal ganglia. It's the most common site for reperfusion, bleed, and hemorrhagic transformation. It's possibly due to higher metabolic demand, vessel wall failure because of the perforated supply and the type of supply, and it bears the brunt of ischemia. The cortex is relatively well spared via leptomeningeal collaterals, so we get more time to salvage it. Subcortical early flare changes and anterior LVO could possibly be a case-based tissue-based marker. Until now, it has been considered temporal-based marker. It be a tissue-based marker in favor of directed mechanical thrombectomy, because we have seen that these patients, when they undergo IVT followed by mechanical thrombectomy, they develop a very large subcortical bleed. And also, I'd like to find you that there should be a change in paradigm from temporal markers to tissue-based markers for decision making and outcome prediction for ischemic tissue. Thank you.
So, Shashank, I think it's a very good case, and I fully agree with your thinking and your decision. Basically, first thing which is very obvious here is that there's a big penumbra in this patient. That's the first thing which we have to see, because there was a NIHS of 24, and for a NIHS of 24, I would expect to see entire hemisphere being knocked off. But it was not. There was a small. That means rest of it was definitely it was dysfunctional but not dead. So therefore, it was a good patient to intervene. The other interesting thing is that there was a flare change here. Now, flare is, as you rightly said, it's being taken as a marker of time, because the average of flare appears at 4.5 hours. But that is the average, that is the mean. In fact, flare can appear as soon as 2 hours, and flare can sometimes appear as late as 7 hours. So therefore, when we use this flare thing, we use it only in wake-up strokes. In other strokes where you suppose if a patient comes to you at 4 hours and his flare changes are there, you would still give him IV thrombolysis. You would not worry about flare at that time. This flare we use only when we have got a unknown onset of time. Then we use it as a marker. We use it as a marker, but it may not be that accurate. So therefore, you are very sure this patient you are very sure that this patient came at 2 hours. He reached you at 2 hours. So therefore, that flare, the importance of flare only is, as you rightly said, it's not a time. It means that there is a lot of tissue damage to that core area. That a lot of damage has occurred. That's why the flare has appeared. But that would not change your decision. So that's also correct. And now comes the main question which you have raised. That is the main question. That should you have done a IVTP or not? I think your decision was very correct in this time, because if you had done if you look at the data also, in data there is not much difference between the bridging and the non-bridging. It's almost same, except that there is in some studies there has been shown a little better outcome when they have done the combined bridging. And the reason, the explanations they have given, it probably broke down and liquefied the clot. Therefore, your mechanical thrombectomy became a little easier. But that is not in all the cases. There are some studies where it has been found that direct has done better. And generally, the situations where direct people do, in fact, there's an equipoise between doing between doing bridging and between doing only mechanical. There's an equipoise. That means both parties are happy. Those who want to do direct intervention, they're also happy, and those who want to bridge, they're also happy. The data does not go against those who do direct. Data says you can also do, and generally the situation in which they choose to do direct is that if it's a very big stroke where you are afraid of bleeding, or if there are already some little hemorrhagic transformation where you are afraid of the TPA. And the third interesting indication where you can do direct, which you must have read in literature, and I think that applies to your case, where you feel that doing a IV TPA in fact will waste time, because your puncture time is too short. I mean, you can immediately do the mechanical by the time you get your thing, and before that you can do it. And I think that's what you saved more time by doing direct thrombectomy. And I think there is definitely a case for doing the direct thrombectomy in given cases. And I think in this case also, I would agree with you. But you were also very lucky that this patient did not have an ICAD. In fact, Yeah, in fact, it is in the ICAD where there may be some theoretical advantage of doing the IV because it softens that rough terrain and all. Once there is a cardioembolic or any embolic thing, it's always better to pull it out and easily. You don't have the first pass, second pass, third pass, and all that thing. So I think it's a good thing. It only tells us that in spite of the guidelines and all, in individual cases, we can take our decision. And I think it's a good learning for all of us. Thank you very much. If there's any other, I don't know whether Praveen, over to you. You can ask him any question, Praveen, or any comments.
Yeah, sorry for the delay in joining, but
You're
one thing
busy.
was
You're
that
busy, Praveen. Busy people join late.
sorry. Very sorry, Shashank. It was a pleasure listening to the presentation. One point I wanted to make: when I saw the basal ganglia bleed, I got little worried, but the functional recovery what the patient had was amazing. Therefore, as they say, definitely we should all such patients with high INHs should receive thrombectomy, and these are the cases which gives us confidence to keep on trying. Great job.
Thank you, sir.
Yeah, good, Shashank. So do you have time for the second case? I don't know. Shivram has how many cases? Shivram?
Sir, only one case, sir.
And how long? Is it big or is it 10 minutes?
Short one.
Okay, so then you go ahead, Shashank. If Shivram has a short case, then you go ahead, present quickly.
Okay, sir.
If at all you have it.
I'm ready, sir.
Yeah.
1 minute.
Nothing like cases. We like cases. Don't feel pressurized. If you don't have it, you can present next time.
No, sir, I have it, sir. Just sharing now.
But Shashank, in your case, there was no pre-thrombectomy bleed was not there. It was later on, right?
Yes, sir.
Because if you had a pre-thrombectomy bleed, no, that would have become one more indication for doing mechanical directly.
Yes, sir.
But you can always defend. Let me tell you, I have surveyed this whole literature. Even when you have done the direct mechanical thrombectomy, you can always defend it. But you have to give some reasons.
So I think I got lucky in that case also because it turned out to be a cardioembolic stroke. He had occult AFib, eventually found out.
Yes.
But I think key feature here was there was collateral failure. That was possibly why we were a little more confident to go for DMT because
yes.
it was an acute thrombus that was there.
Correct.
So I'll quickly try to go through this case, sir. So this was a female 57-year-old lady, the SV. She had a history of large and small joint polyarthralgias, was being treated as seronegative RA for the past 9 years because the family history was positive. She was dyslipidemic and also had hypothyroidism. So she presented, 1 minute. So she presented with headache for the past 4 months, which was bifrontal, typical migraines type with light and sound sensitivity. There was change in character in the past 4 days before prior to presentation with increase in severity, continuous nature, and she had a lot of episodes of vomiting. And then she also developed rest angina. So there were no identifiable triggers at that time. There was noted that she was developing a rise in BP whenever the headache crescendoed, which could be possible because of the pain. There was no fever, head trauma, or seizures. MRI brain plus MR venogram done outside was normal. Tropi was interestingly elevated outside. CAG was done outside before she came to us. She had mild CAD, which was not explaining her uh, uh, angina and the elevated tropi. So it was initially thought it was possibly a cardioembolic MI that she had, which is recanalized. But again, there was no evidence of why she was having headaches. So at presentation, her BP was 140/80, fundus was normal, there was no deficits, contrast imaging was repeated at that time. She was having a small tiny infarct in the posterior circulation area, as you can see, with flare changes noted here in the medial occipital lobe. MR venogram was normal. Her ESR, CRP, and creat were normal. She underwent a DSA, considering we were thinking of possible press RCVS phenotype, and we wanted to look if there was an aneurysm that we were dealing with. This is the puncture, sir. I was not able to sort through the slides, sir, but I'll go through them quickly. So this is the right ICA shoots, and you can see from the get-go itself that there were multiple areas of narrowing. This is the PCOM, and there were multiple alternate areas of narrowing that was noted in the PCA artery. And this is not only limited to the posterior circulation. In the anterior circulation also, the medium and small vessels showed multiple areas of narrowing and dilatation, which was reminiscent of possible vasculitis. These were the vertebral shoots, with the vertebral showing very, again, sausage-like appearance of the bilateral. I'll just turn on my laser pointer, sir. 1 minute. So there was, again, vertebrals were showing areas of narrowing, which were nearly going for occlusion. There was in the pica, you could see areas of narrowing, and then even the PCAs. So moving forward, this was bilateral, both anterior and posterior circulation is what I'm trying to make a point here. Day 3, her RCVS score here was 1 or 6. If you consider now that the issue with RCVS score here is that it gives 5 points to the worst headache of your life. Now we've noticed that in some people with RCVS, that they have a stoic nature, they don't really complain that it's a very bad headache. I've had these headaches from before also. But considering RVS, she was started on nimodipine oral. Her headache substantially reduced on day 3, but albeit recurred intermittently the next day. She underwent vessel wall imaging because we were again confused, are we dealing with RCVS or vasculitis? We were having a higher consideration for vasculitis at this juncture because she had history of hypothyroidism, she had history of rheumatoid arthritis. Her CSF was normal, cultures, TB fungal cultures were negative. She received a IVMP dose of 500 milligrams. Now this was the vessel wall imaging just on the day of when she received IVMP. We can see that there was no typical vasculitis kind of changes. There was some enhancement that was noticed along all these vessels that you can see. There was enhancement along all the cortical vessels and the small vessels. But this is not typical of the vasculitic changes that vasculitis kind of changes that you see in vessel wall imaging. Now, this is just enlarged images where you could see there was some enhancement in the ICA. This could be debated that this is just the normal enhancement that you see with any contrast injection. Her CSF was normal. There was no evidence of OCB. There was no evidence of raised protein index. So again, we were at a loss here. There was no evidence of CNS inflammation. Now, her ANA panel also came back to be PML SCL 100 borderline positive, again, which was not really conclusive towards anything. Her lupus panel and hypercoagulability also came back to be negative at this time. So we had quite a lot of information for this patient at this juncture. She had strokes. She had features of RCVS versus vasculitis, but this was involving the supra and antitentorial. Now, again, if we look at this juncture, there were not many flare changes. There were not any histories of bleeds to suggest vasculitis in this juncture. So again, RCVS takes a precedence here. But this patient, what happened was, for what benefit of doubt, we gave her IVMP at that time. So she developed mild confusion and inattentiveness. After that, the BP and clinical exams were normal. She was advised an MRI SOS when her headache worsened and she developed left hemianopia. Now, sparing this medial occipital lobe, we could see that there was new infarcts that she was developing in the posterior circulation area. And we could see there was, again, the narrowing was worsening in the MRI TOF. This patient received, in conjunction with some multidisciplinary management at that time. So rheumatology advised that she receive tocilizumab and IVMP at that time. She went on to develop quadriparesis and cortical blindness and encephalopathy. Stroke protocol started showing these infarcts, which are very reminiscent of press actually. And now we do realize that then there was some hemorrhagic transformation also. Now we do realize that these press and RCVS are now considered to be along one line of a spectrum, where if the infarcts do occur, they can occur with RCVS also. Now this again at this point, RCVS versus RPLS we were thinking of. We escalated nimodipine, we started IV magnesium, but there were no identifiable triggers. But we were able to find out later on that this lady was started on SSRIs around a month back for her headaches, considering that they were considering that she had some depressive component. But what about the vessel wall imaging? Now looking back at the review of literature, 50% of vessel wall imaging in RCVS also shows enhancement with incongruity in 1/3 and persistence of these vessel wall changes that even occur after the RCVS changes have been normalized. So that is not, these are vessel wall imaging is really not helpful to differentiate between, in some of the cases, between vasculitis and RCVS. What we possibly could have done at this juncture, retrospectively thinking when hindsight is 2020, is that we could have given IV nimodipine during the initial DSA and to see if that the vessel wall changes were reversing or not. But here, our patient possibly went on to develop poor prognosis because she was exposed to glucocorticoid therapy. Now, this raises a point that you should be able to differentiate between RCVS and vasculitis on your first DSA, because exposing this patient to glucocorticoid therapy might worsen the case of RCVS. And she also developed infarctions, which was a bad prognostication factor. And her basic clinical factors of advanced age and comorbid conditions were also poor factors. She did receive Plex, but it could not be continued. She developed blooming on this thing, so it was stopped. Spasticity she developed myoclonic spasms. CT brain was done, which was showing established infarcts in the bilateral posterior hemisphere. Aggressive anti-edema measures were improved, and I forgot to mention she was started on IV nimodipine prior to the Plex. So this patient, she eventually did improve, but she did have some developed an MRS of 3 at the end. She did regain some of her vision back since the medial occipital cortex was spared. And good thing was that she came back for follow-up, and at a repeated DSA at 6 weeks, we could demonstrate that all the changes that we had noticed earlier, as you can see in the repeat DSA at 6 weeks. Particularly the changes that you could see in the right PCA infarction. Although there was some persistence in the bilateral vertebrals, the intracranial vessels seem to have opened up now. So I just want to let me just finish this. This was the PCA which we had seen earlier. Now it was showing a smooth wall right now. So this is just to summarize. Again, RCVS score is a little skewed because you can see that 5 points go towards a recurrent or single thunderclap headache, and that really does change your diagnosis if it is RCVS or not. That single fact can change your diagnosis here. And few features that I wanted to drive over in vasculitis, you should suspect vasculitis if the patient has a lot of flare changes, has a long-standing history of headaches with recurrent strokes and possible bleeds. In this kind of scenario, this was more favorable of RCVS, where we possibly caused more harm by giving glucocorticoids. But luckily, the patient eventually did receive IV nimodipine, and we were able to salvage her. So yes, sir, that's my second case.
Praveen. Dr. Praveen, are you there?
Yes, sir, I'm here, sir.
Comments?
First, what was the
Hello?
Can you hear Praveen?
vasculitis? Are we dealing with a RCBS and a press? Looking at the pattern of the flare involvement, definitely it looks more of a press rather than vasculitis.
Yes, sir. We were a little skewed because there was a lot of anterior circulation involvement also, sir. And then there was also a background history of autoimmunity, rheumatoid arthritis, and hypothyroidism. So we kind of got a little bit of derailed there in that, I think, that situation. Now, hindsight, looking back, yes, it does look like it was possibly we were dealing with RCVS, which went on to develop bilateral posterior hemispherical infarcts. Maybe if IV nimodipine was started a little earlier, she wouldn't have possibly developed those infarcts also.
Very difficult to say.
No, yeah. The IV nimodipine it's given, but it's not proven for RCVS. In fact, there are reports that they have worsened with that also, with nimodipine also. But this case is definitely, now that angio is showing, it's reversible, so we can't question it. But usually RCVS we have not seen in such, the age is she is a little bit older for RCVS. What do you think? Usually we're seeing in young people, but it can occur at any age. And what could be the reason you think? The only thing is antidepressants, right? SSRI.
Yes.
That was the only thing I could elicit, sir. I was not able to find any other triggers there. That also, later on we went through our medications, and then we found one prescription of escitalopram. So a little far short, maybe possibly that it has to.
Totally SSRI, amitriptyline, all of them are known to precipitate. Therefore, many of times we are the culprits.
Yeah, but the usual phenotype is young girls with migraine history, and then they get these amitriptyline and all, and then they develop it. But diseases are a spectrum. Anything can happen. This is again an eye opener for us. That at all ages you have to think of all the diagnosis. And fortunately, she did well. And the topography of the lesion was quite reminiscent of press only. As you rightly said, press and RCVS, they are part of the spectrum. When you see the beading, it becomes RCVS, and when you don't see the beading, they are probably smaller vessels. Then that's why they lead to press. But these are all dysregulation, vascular dysregulation syndromes. So anyway, good. Shashank, thank you very much. I think both your cases were wonderful. Thanks a lot.
Wonderful. Wonderful cases.
So let's go to now
Thank you.
Shivaram. So welcome, Dr. Shivaram. Hello, Dr. Shivaram.
Sir, can you hear me, sir?
Yeah. Welcome.
Is the screen visible, sir?
Yes.
Yes. Yeah. So, good evening, sir. Actually, this is a very proud moment for me to present in front of Cole, sir. Actually, he was my first teacher as soon as I joined DM Neurology. So this case was very learning experience to me. Even like prior to this, as sir has told, like each case is a learning experience for us. Prior to this, I never knew that this type of thing was even possible also. And great cheers to our interventional team who has done this procedure and all. So coming to the case and all, he was a 62-year-old male patient who presented with sudden onset of hemiplegia with global aphasia and all, and he presented with almost 2.5 hours of presentation. He had a very high NHS score, and the most important thing was he was non-diabetic, and only the blood pressure was around 160 at the time of presentation, 160 by 90 or 100 like that. But with he was not on any previous antihypertensives, and he did not have any kind of smoking, any comorbids, and no comorbids, and no nil, no smoker or alcoholic and all, no tobacco chewing and all. And coming to the MRI, this is a diffusion scan where you can see this left MCA infarct was there with predominantly in the subcortical area, and also it's extending into the cortical aspect. And flare sequence was not showing any significant changes and all. And in the GRE sequence, you can see there's an acute thrombus which is there in the MCA area, MCA vessel. You can see there's acute thrombus which is there in the MCA, coursing across the MCA. And this is acute infarct in the left MCA with no significant flare changes. But the angio was the 3D TOF image, especially in the MRI, was the complete ICA was non-visualized and all. And ICA and MCA both are not visualized in the TOF. And because it was a window period, we immediately thrombolized with the tenectal place and called for our interventional team, who took him for DSA. And during the process, when they tried, when the DSA, left CCA was cannulation was not possible, and even multiple attempts we could not pass catheter and all, and there was a complete opacification of the left CCA, and left subclavian also was not visible. And when there was one most important thing was there was no cross flow also via ACOM. And when multiple runs of were done through the right side, there was no circulation that's going on to the left side. We suspected that there could be some it could be some thrombus, or there could have been aplasia of the ACOM aneurysm, anterior communicating artery and all. And normally in these kind of cases and all, especially when there's when catheterization is not possible and we can see an acute thrombus sitting out there, usually sometimes direct carotid puncture is done. Normal procedure is usually we go through the anterior grade, but in this case, possibility, even if we gone through the anterior grade and remove the thrombus, if there's no flow from the opposite side, the process of doing a direct carotid puncture and removing the thrombus would not be successful, because when it's not filling through the other side, the left hemisphere will be isolated, and there's no point in removing the thrombus and all from the MCA through direct carotid puncture. So in this case, what we have done is we have went to a retrograde approach. Our intervention team has come up with this novel idea, where they did a direct carotid puncture, pass the guide wire through the left carotid down into the CCA. It was possible because even though the angio was not showing anything, when we checked with the Doppler, small flow was there. So probably because of the probably is a small probably there could be 99% occlusion and only 1% small passage was there, and through this the guide wire could be passed and all, and which we noticed in the Doppler, but those were not coming in the film in the angio runs and all. And this and after sending the guide wire through the from the carotid into the aortic arch, then a small snare was passed to the femoral axis, and first they have done a left CCA the angioplasty was done of the left CCA, and and then normal thrombectomy was done. So snare was passed, and the guide wire was attached to that, and you can see that normal angioplasty was done, and after that the routine thrombectomy was done after opening up the CCA. So recanalization was successfully achieved in this case with a single pulse, and after complete clot removal was done, and total procedure time was around 60 minutes from puncture to the recanalization. So this was a post procedure MRA after 24 hours. Like there was no new fresh expansion, and complete recanalization was done of the left IC and MCA, and this was a follow-up angio, the CT angio after 1 month. You can see that mild stenosis was there at the left ICA origin, and otherwise the flow and all is very good, and patient is now almost up to 3 to 4 months of follow-up. Like he's perfectly all right with just Vicosprin and clopidogrel and all. So sometimes what we say is that desperate times require desperate measures, because when we search through the literature and all, lot of studies are there of direct thrombectomy, but in this case probably we were not sure whether direct thrombectomy would direct carotid puncture and anterior grade thrombectomy would have helped him. So we had to go down, open the first two angioplasty of the CCA, then pass the catheter and remove the clot from the MCA and all. So probably this could search the literature but could not find any cases like that. But sometimes each case is different, and we need to have a different approach for in each case. Thank you.
I think this is just amazing. I mean, I have never heard about it, and it must be. This means that normally people would have probably given up once they were not able to, do the cath, and they would have found the, normally from aorta only they do the cath, and once they would find a block, they would say that there is an organized thrombus. It probably cannot be done. But the idea that from above, distal to the block, not even distal, they have gone into the block themselves, into the clot itself, and
Actually,
then gone down.
when they did the Dopplers initially, they could see small flow passing through the CC and all, which was not
Yes,
seen in
yes,
the angiographic runs. And
yes,
probably when we're trying to cannulate through the aorta, it was not going through. The catheter was
yeah.
not.
So
So
that streak of blood meant that there was probably some hole or something, some passage through which they could
right,
have passed. They
yes,
passed that.
sir.
Yeah. And
And
then finally they were able to suck out the whole thing with the snare and all.
yes, sir. And after passing the snare, they did a angioplasty first of the common CCA part. Predominantly at the ostium, it was there. The block.
They did only angioplasty, not stenting.
No, sir. Only
Yeah.
angioplasty of the common carotid. Then passed the normal thrombectomy catheter and did routine thrombectomy of the MCA and all.
Yeah, no, this is amazing. I have seen one similar case which Dr. Ichapuria often shows, but that was about a superior sagittal sinus thrombosis where they did a hole into the skull and took out from the superior sagittal sinus the whole clot with the help of some scissors. So these are very rare things, but then you did an amazing thing. You saved the life of the patient.
Dr. Sanket was a neurointervention team, sir. He was
Yes,
the,
yes.
the procedure and all.
Amazing. I think this only shows that there is no limit to our
Mhm.
imagination and then practical aspects of that imagination. He
Was-
must have probably read somewhere, otherwise he wouldn't have done it. He
No.
must have seen some case reports or something like that.
Actually, there was no case. Went back and seen the literature. There was no case report, sir. Actually,
So this was purely his own innovative.
his own innovative thing.
Then
And
this
even
should be
there was-
published as Sanket's
Yeah.
technique. Sanket Shivram technique.
No, sir.
Praveen, over to
Yeah,
you.
yeah. That was I was waiting to say, Dr. Shivram, you should publish this case. This should go places. The way it
Publish
was
with the
done.
name Sanket Shivram technique.
Wonderful,
Yes,
sir.
yes.
Yeah. Yeah, the
But
cases discussed were
because I think
amazing.
left side, see, a lot of disability to the patients. Left side infarcts will cause
Agree.
aphasia.
Agree. Yeah, yeah, yeah.
So something has to be done at that point.
True, true. And with no cross flow, obviously the patient would have a devastating hemiplegia.
Yes, sir.
Therefore, hats off to the team.
Yes, sir.
Yeah,
Thank.
great.
Very good. Very nice presentation. Very good learning.
Requesting
So-
yes, sir.
Yeah, please go ahead. Go ahead.
Yeah, requesting my team, Krishna, please let me know if there is any question from the audience.
Hi, Dr. Rajeshri. There are actually 3 questions from the audience.
Okay.
Please
So-
go ahead.
The first one is how we can identify wake-up stroke. Generally, PT and PT attenders unable to say when time starts, when they are unable to say the time of recording.
Yeah, Shashank, you can answer that.
Yes. Sorry. Shashank is there?
Shashank, Praveen, you can hear that question?
Yeah, yeah, I heard it.
Praveen, then you
Shashank
can
is there,
answer.
sir.
You can explain, Praveen, to them.
Yeah. Shashank, will you go ahead or shall I?
Sorry, sir, I was not able to catch the question clearly. My speakers.
Oh, so Praveen, you only go ahead. Praveen, you only
Yeah.
go ahead.
Yeah. The talk was that of always the dilemma which we face, wake up stroke, right? What was the possible time when when the patient had a stroke? Because when we say that the patient has when last seen normal, that is when he was awake the last night. Therefore, always the time is about 8 to 10 hours, right? Therefore, we don't qualify it. There the wake up trial, the pivotal wake up trial which came in NEGM showed the way out that if the patient if there is a change in the diffusion, but if the flare the changes are not yet there, it means that possibly the stroke is within the 4.5 hours window. As Shashank rightly told, the flare changes take about 4 to 6 hours. Therefore, by mean, if we can take, therefore, if there is no change in the flare, change in the DWI, it means that, that there is 4.5 hours window and we can definitely thrombolize. And after that, definitely looking at the vessels, we can take the call. But thrombolysis, by looking at the diffusion flare mismatch, we can definitely go ahead.
And Praveen, can I add something to that?
Sir, always, sir.
No, something interesting, As you rightly said, when there is a wake-up stroke, we go by the flare changes as a surrogate marker. So surrogate marker means, that means if there is a flare, that means the stroke has occurred at least 4.5 hours before. When it has occurred, we don't know. But what we know is that 4.5 hours have passed. Now, suppose if somebody asks us, no, okay, it has occurred before 4.5 hours, but when it has occurred before 4.5 hours? So, patient yesterday went 10 o'clock to sleep, and today morning he has woken up at 7 o'clock. Now, it is assumed that you take the middle of the time from his going to sleep and waking up.
Okay.
And it's assumed for statistical purposes that the stroke has occurred at the midpoint of the sleep. And there is that 9-hour trial. So they say that if it is less than 9 hours, then you are having a good thing. But how do you know 9 hours? Well, exactly. So they assume it. that it is to taken in the midpoint of that. That is just as an additional point. But that's an assumption.
Yeah.
If you have to assume. Yeah. Okay. Next question.
Yes, sir.
This has come from European Stroke Association. Yeah, please go ahead.
So the next question is, recently there is a listening about tirofiban in stroke progressing cases. Can we try it regularly?
I think Shashank only can answer that question. He has done a fellowship
Yes,
in
sir.
intervention.
So,
Yeah.
tirofiban has a role in branch atheromatous disease where the infarction is not already occurred. This is like for stuttering strokes where it has shown to have benefit. So we have used it for a few cases. Many of them have invariably progressed to develop strokes because branch atheromatous is very difficult to treat. Secondly, if the patient does not bleed, Colser always repeats this, that if the patient does not bleed on tirofiban, then you're lucky that the tirofiban is successful in that situation. Patients can bleed very profusely and very badly, and especially if the patient has already developed an infarct and the tissue, infarcted tissue is large, there is no role of tirofiban. It actually might be quite catastrophic. But yes, if there's no infarct, that is, I had used tirofiban in one patient who had a left pica territory branch atheromatous like presentation where he was having these recurrent episodes of facial pain. We initially thought we were dealing with some kind of TAC or craniofacial pain, but then this eventually we were able to notice that he was having meiosis and he was having some anhidrosis. So then we realized that this patient was going in for a left pica territory. We did a DSA. There was an aberrant pica artery with a plaque sitting in the left vertebral. And then we started this patient on tirofiban, but unfortunately he did progress to develop a pica territory stroke, which was a small stroke, and luckily which did not bleed. But yes, uh, issue was again is that if you put the patient on tirofiban, then while is he on that? If he develops a stroke, can you give him altiplase at that time? So you might be denying the patient altiplase if you start the patient on tirofiban, which is a 24-hour to 48-hour infusion in some cases. So I'm not sure what how he stands on tirofiban, and Praveen sir.
See, I have for the first time heard about this. It's actually a glycoprotein 2B3A inhibitor. You know, so it is kind of a 2A 3B inhibitors are actually their antiplatelet agent, but say IV antiplatelet agent, 2A 3B inhibitor. And I have for the first time it being used by Anantram, our interventional neurologist. And then I realized I came to know that most of the interventionalists, and you are also one of them, they are very comfortable with this drug. So what happens is that when they do the intervention and during the intervention, suddenly if they say something has got thrombosed, some stent has got thrombosed and all, then they run a infusion of the tirofiban to dissolve that clot at that time. This is almost a, but as far as neurologists are concerned, there are two things in which it has come into limelight. One is which you yourself made a reference to, what's called capsular warning syndrome. Now, capsular warning syndrome is in which you get multiple crescendo TIAs, which means you can get 10 TIAs, 20 TIAs, stroke of TIA after TIA after TIA. They are actually because of that, what you say, branch atheromatous disease, which means they are penetrating artery TIAs. And it has been shown that tirofiban can put a stop to them. It can stop. So in that context, it has been used. And but there is also some literature, Praveen, and I think that probably we discussed it once, that it has been tested in preventing the progression of the stroke. And it has been given after TPA has been given. That is funny. After TPA, they have given tirofiban, but it's only at a trial level. But it is not. It's not. It's not. It is very hot. There are no guidelines which give tirofiban in our day-to-day practice. Yeah. Next question.
That's it. There are no more questions for now.
Oh, that was great then. It was a great learning. And I think thank you, Shashank, thank you, Shivaram, and thank you, Praveen. All of you are brilliant. I'm going to tell you, all of you are the real stroke experts, and it's a joy to interact with you, learn from you. And thanks to Rajeshri Dhar and for the entire team of Gennova. Now, it's not MCure, it is Gennova. It's a new team, Gennova, entire Gennova team. Over to you.
Thank you. Thank you so much. Thank you so much, our esteemed faculties, Dr. Kausar and Dr. Praveen. for giving us so much insights, and our speakers, Dr. Shashank sir and Dr. Shivram sir. Definitely those insights will be very helpful for our audiences as well. And our sincere thanks to all the participants out there who managed to be here, giving us so much time from their busy practices. We appreciate your efforts, and also the entire Gennova team, the technical team, without whom it would not be a great event tonight. And we look forward seeing such more cases from you all. Definitely we'll meet you in person. Thank you so much and very good night. We'll wind up the session right here. Thank you.
Thank you.
Thank you.
Bye-bye. Thank you.
Good night.
Thank you, sir. Thank you. Thanks a lot.
Thank you, technical team. You can close the meeting and close the recording as well.
Thank you, ma'am.